Hi friends, welcome back to BGS Clinics. In this clinical class, I will discuss the principles of treatment. In other words, how to plan the treatment for your patient. For that, ponder over 2 points. First, obviously the diagnosis and the stage in the natural history of untreated disease at which the patient has presented to you. And second, the state of health, hydration, nutrition and performance of the patient. What exactly do you mean by this? The stage in the natural history of disease, and why should you consider it? Well, the term stage of the disease is conventionally used while discussing cancers. However, stages do exist even in benign conditions. Stages basically may be looked upon as important stations in the journey of a disease. At each station, the pathologic anatomy and consequently the symptoms, signs, and investigation reports change in quality and quantity as compared to those on the previous stations. In accordance with the change in pathology, treatment strategy also needs to be changed. Let me explain by taking a common example. Acute early appendicitis, appendicular lump, and appendix abscess may be considered as three important stations in the journey of acute appendicitis. Okay, pathologically, catarrhal, phlegmonous, and suppurative appendicitis correlate with what is clinically labeled as early acute appendicitis. Although the standard of care at the early stage is urgent appendicectomy, a conservative approach may have to be considered in some situations. The standard of care of appendicular lump is conservative. In patients who respond to conservative treatment, a surgical treatment, namely interval appendicectomy, may be considered for them at a later date so that they never suffer from appendicitis again. There are two schools of thought about that, however, because not all patients suffer from recurrent appendicitis and therefore can get spared of appendicectomy. So, some surgeons recommend interval appendicectomy only in selected patients. To conclude, after successful conservative treatment of appendicular lump, some patients go for interval appendicectomy later, whereas others get away without it. The standard of care for appendix abscess is drainage of pus, either percutaneously or surgically. When drained surgically, appendicectomy also may be carried out at the same time. There are two schools of thought here again. Many surgeons prefer to only drain the pus, leaving the appendix behind at that point of time, whereas others knock off the appendix at the same time. Personally, I prefer to perform appendicectomy at the same time as surgical drainage of abscess. Thus, one cannot make a general blanket statement that appendicectomy is the treatment for appendicitis. Are you convinced now as to why it is important to look at the stage in the natural history of a disease at which the patient has presented? That is why it is important to learn pathology very well. So, keep these points in front of you while planning the treatment. Complete diagnosis, including the stage in the natural history of untreated disease at which the patient has presented to you, and the state of health, hydration, nutrition, and performance. Now, coming to actual planning of treatment. For that, answer the following 4 questions. Why, what, when, and how? Why treat? Why not leave alone? For example, a lipoma without absolutely any suspicion of malignancy, a small direct hernia in an elderly, incidentally detected renal cortical cyst on ultrasound scan, etc., can all be left alone. What are the indications for surgical treatment then? Severe functional disability, the pathology which demands surgical treatment without which cure or control is not possible, complication, failure of conservative treatment, a disfiguring cosmetic appearance following an injury or disease which is unacceptable to an individual, and on patient's demand, for example, for cancer phobia. That means a patient with a small lump or bump will be restless due to fear of it being malignant and be after you to knock it off. Please remember, however, that if you are convinced about benign nature of the lump, then before accepting patient's demand, you should try to persuade the patient to refrain from unnecessary surgery. The next question to answer is what to treat. You need to treat the homeostatic imbalance if present, the index pathology itself for which the patient presented, including its etiology and complications if any, plus any comorbidity if present. All these points may not be applicable in every case, but you must always keep them in mind so that you do not miss any of them where they are applicable. Take, for example, a patient with acute intestinal obstruction requiring a surgical treatment. Such a patient will be severely dehydrated with shock and in electrolyte and acid-base imbalance, which means there is a severe degree of homeostatic imbalance. You must spend around 2 to 4 hours at least in resuscitation. That means adequate rehydration with intravenous infusion of crystalloids plus correction of electrolyte and acid-base imbalance before taking up the patient for surgery. If a patient in shock is anesthetized without prior adequate resuscitation, then the shock will accentuate due to hypotension, which usually occurs soon after inducing anesthesia, may it be general or spinal, and that will further suppress the myocardium, leading to acute cardiac failure. Also, in the post-op period, kidneys are likely to shut down. Hence, it is extremely important to correct the homeostatic imbalance when present. This is the third point to address. Do you operate on the patient as an emergency case, urgent case, early case, or an elective case? Please note, there is a difference between emergency and urgent. Emergency means you got to operate within minutes. Diagnosis is made essentially clinically. A quick ultrasound scan may be done while resuscitation is underway, and then the patient goes straight to the operation theatre. Patient will not survive if you waste time on thorough elaborate investigation. I will give you a couple of classic examples. An old patient presents with acute pain in lumbar area, collapse with hypotension, and having a lump in abdomen which may be pulsatile. What will be the clinical diagnosis in such a case? A ruptured abdominal aortic aneurysm. Commence resuscitation and proceed directly to the operation theatre if surgery is indicated. Now the second example. A woman in childbearing age group presenting with acute pain in abdomen, more so in one of the lower quadrants, bleeding PV, and in hypovolemic shock. Which diagnosis will you strongly consider here? Acute rupture of ectopic pregnancy. Alright. Urgent means operate within hours after adequately resuscitating the patient if dehydrated and also under antibiotic cover if the patient is septic. Within hours means within how many hours? In conditions like acute peritonitis, acute intestinal obstruction, within 2 to 4 hours or at the most around 6 hours. This is the usual time required for adequate resuscitation. In cases of sepsis, like for example acute appendicitis, carbuncle, etc., you may operate within 24 hours or so. During this time, the antibiotic treatment will take effect, and particularly in case of carbuncle, you will also be able to correct the metabolic derangement such as hyperglycemia, electrolyte imbalance, and acidosis. Early means operate within a couple of days. basically meaning operate during the same hospital stay. This strategy turns out to be convenient and economical. The classic example is acute calculus cholecystitis. Commence conservative treatment and post the patient for cholecystectomy on your earliest routine operation theatre list, which usually falls in a day or two. This has now become the standard of care for acute cholecystitis. Previously, the standard of care was different. As a matter of fact, that is practiced even now in many places, and that consists of commencement of conservative treatment to which most of the patients respond, and then post for elective, that is planned cholecystectomy after at least 1.5 to 2 months. That is the time required for complete resolution of acute inflammation. And then decide how to treat. Let us first see what are the options available, and later I will explain how to select the most appropriate one out of them. The first option is so-called expectant line of treatment, wherein you keep the patient under regular follow-up. The frequency of follow-up varies from case to case. At any point of time during the course of follow-up, you may decide to intervene if indicated. The dietary treatment essentially means to suggest qualitative and or quantitative modification in diet. Just to give a few examples, curtail or avoid sugar in diabetic patients, curtail salt in hypertensive patients, curtail calorie intake in overweight and obese patients, etc. Postural treatment consists of appropriate positioning of a part of the body or the entire body. For example, limb elevation, sitting up, head high, head low, etc. Modification or omission of physiological activity may be necessary in some situations or after some surgeries. For example, avoiding eating, avoiding sexual activity, avoiding weight bearing on the operated limb, avoid walking altogether, or complete bed rest, etc. Lifestyle modification may involve change of a kind of job to another one, or sometimes a total change of career. For example, a patient suffering from a peripheral arterial occlusive disease whose job involves a lot of walking or cycling will have to get his job changed to office work. A patient with chronic venous insufficiency whose job involves long hours of standing may also have to get her or his job changed to the one which will not involve long hours of standing. This is yet another modality of treatment. Dressing, bandaging, and use of appliances like elastocrete bandage, elastic stockings, cast, collar, mold, belt, etc. Application of heat in the form of fomentation, inhalation, shortwave diathermy, etc., or application of cold may be indicated in some disorders. The so-called medical treatment comprises of administration of medicines, infusion of intravenous fluids, and transfusion of blood components or plasma products for various indications. There are several routes through which medicines may be administered, namely the oral, rectal, surface application including transcutaneous, parenteral, and local injection in a lesion, in or around a nerve, in or around a vessel, or in a cavity. These are some examples of local or focal injection. Intralesional injection of a steroid such as triamcinolone acetate, nerve block, injection of a sclerosant in a pile or esophageal varix, embolization of a high-flow congenital AV malformation, intrapleural injection of tetracycline or other chemotherapeutic medicine for controlling malignant pleural effusion, etc. And then you have some more options of treatment such as aspiration or suction, Instrumentation, for example, catheterization, dilatation using balloon, bougies, etc., stenting, endoscopic extraction of a foreign body, and so on. Interventional radiology, radiotherapy, surgery, and various permutations and combinations of all the above. So, these all are the options of treatment in sort of ascending order of perceived invasiveness. Expectant line of treatment, dietary modification, postural modification, physiological modification, lifestyle modification, dressing, bandaging, appliances, application of heat or cold, medical line of treatment, aspiration or suction, instrumentation, interventional radiology, radiotherapy, surgery, and combinations. Now comes the last step, selection. Selection of the option and selection of the place to treat. Select the most appropriate option taking into account these factors: the state of health, hydration, nutrition, and performance. These parameters will let you know if the patient will be able to withstand the option of treatment selected or otherwise. Look at the success rates, that is, the rates of sequelae, complications, and recurrence versus permanent cure. And other factors to consider in selection include gender, occupation, affordability, availability, and compliance, and then decide whether the selected treatment can be imparted on outpatient basis or else requires hospitalization. And now a brief discussion on follow-up. The timing of the first and subsequent follow-up visits after discharge from hospital will vary from case to case. What will you review at the time of follow-up? Evaluate the outcome of treatment. Is it as was expected or turned out to be otherwise? Has any complication developed? After assessment, recommend modification, addition, or omission in the ongoing treatment and request cross-references if needed. And study the case from point of view of natural history of the disease so that the next stage in the pathology can be anticipated and necessary measures taken in time. This is particularly applicable to cancer cases. So that's how you plan the treatment. This format which I have explained will help you very well. Try it out and don't forget to give me a feedback. Thanks for watching.